This conference will now be recorded.
Today our topic is giant cell tumors of bone. And coming to introduction, giant cell tumor is a benign tumor, but it's an aggressive tumor, typically found in metaphyses of long bones and often around the knee in young adults. But as we say, it is a metaphyseal tumor, but originally it's from epiphysis, like it extends into epiphysis. And coming to the epidemiology, its incidence is 1.7 per million people, and it's more common in females, and mostly in other tumors where you see it's more common in males. But this is the only tumor which is more common in females, and it's more common in middle aged, 30 to 50 years of ages. And coming to the location, it's more common around knee, which is distal femur comes in first position, followed by proximal tibia, followed by distal radius, and last sacral ala. And genetics is important. Like as we already said, it's an aggressive tumor, so metastatic lesions may also be seen occasionally. These metastatic lesions are seen in mutations where we have alterations in c-MYC oncogene or p53 gene. And histological characteristics are important in giant cell tumor. There are three types of cells in histology. First type is mononuclear cells. These are most common. As we see here, these are the spindle-shaped mononuclear cells, which are more commonly seen. Because when we see the name giant cell tumor, we think that giant cells are more common, but it's not like that. Giant cells are characteristic of this giant cell tumor, but more number of cells are mononuclear cells. And second type of cells, they arise from mononuclear cells, but from monocytes or macrophages. These are precursors of giant cells. And type 3 cells are giant cells. See, these are the giant cells, which are multinucleate and osteoclast-like giant cells. So that's why this tumor is also called as osteoclastoma. And coming to the symptoms, as we have already told that it's an aggressive tumor, so there will be insidious onset of pain involving the extremity, which is present with activity at night or at rest. Pain is referable to the involved joint, and especially night pain is present, and difficulty in ambulating, and swelling as it is a characteristic feature of tumors. And on examination, in physical examination, on inspection and palpation, there is a palpable mass, there is tenderness over mass, and there is soft tissue swelling. And if periarticular lesion is present, joint effusion is also present. And palpation, another characteristic feature is eggshell crackling is present in giant cell tumor. It is a characteristic finding. And in motion, there is decreased range of motion around the affected joint. And gait is antalgic gait, because as there is pain, there will be antalgic gait. And coming to the investigations, if you see, first thing we do is X-ray. And in X-ray, recommended views depends on the extremity involved. Chest X-ray has to be taken to see like whether there is lung metastasis or not. And coming to the findings, see, if we see in this X-ray, the lesion is eccentric. This is in the upper tibia, and the lesion is eccentric, and it is lytic. See, there are areas of lysis, so it is lytic, and it is epiphyseal lesion. And if it is in metaphysis, it extends into the epiphysis. And neocortex is characteristic. If here it's not there, but when there is a like aggressive tumor, there will be neocortex formation. It is characteristic feature. So here what we have to see is eccentric lytic lesion. Okay, and these are the X-ray features. And coming to the next investigation, we can go for CT scan. CT scan is also the recommended use depends on the area involved, and we have to take chest CT. And in CT scan mainly, we can see the extension of the tumor, like I mean, in X-ray we can't see complete involvement of the tumor in plain X-ray, but in CT scan we can see the extension of the tumor into the bone, and lung metastasis can be seen in CT. And MRA, in MRA, mainly MRA is done to see the extent of lesion into the soft tissues. In MRA, we can see the soft tissue involvement, so MRA is also important. Bone scan reports are variable, so it's not so sensitive for this giant cell tumor. And coming to the management, management may be non-operative or operative. In non-operative, the management is mainly radiation therapy and medical management. In radiation therapy, mainly radiation therapy is indicated in inoperable or recurrent lesions. And in medical management, coming to the medical management, the drugs commonly used are denosumab, bisphosphonates. These drugs, medical management is commonly involved in, commonly indicated in stable lesions. I'm sorry, here there is spelling mistake. Stable lesions, and augment or just a second. There is a small mistake, I guess. Yeah, this is a second line is a mistake. Sorry. These are mainly indicated in stable lesions, medical management. And coming to the operative management, there are operative management. There are many types of surgeries we do. Coming to the first one, there is extensive curettage followed by adjuvant therapy and reconstruction. And first thing is, if it is a very small tumor, then we can directly go for excision before going, I mean, without going for extensive curettage. So if it's a small tumor, first we can go for excision, and second one is extensive curettage. And in extensive curettage, where we do is where the lesions are amenable to curettage, and majority of lower extremity lesions only we can go for extensive curettage. In this, the technique involved is first we remove the lesion while preserving the joint and providing support to the subchondral joint, followed by adjuvant therapy. This adjuvant therapy is mainly done with phenol or liquid nitrogen or H2O2 or organ beam laser. The main thing under adjuvant therapy is it prevents the recurrence of the tumor, like further recurrence of the tumor is prevented by adjuvant therapy, and followed by reconstruction. Reconstruction is mainly done by filling the lesion with bone cement or bone graft or supplement with internal fixation. So there are three steps here. First one is extensive curettage, where we remove the lesion. Second one is adjuvant treatment, which is done with this phenol or liquid nitrogen or H2O2, and followed by reconstruction. And next second one is complete resection and reconstruction. Here, when curettage cannot be done, I mean, here what we do in curettage, just we remove the lesion, preserving the joint. Where curettage cannot be done, we do complete resection, means we remove complete entirely, including the joint, and followed by reconstruction. And coming to the next one is final resort is amputation. Amputation is done in hand lesions with cortical breakthrough, which are not amenable for resection. So in lesions which are not amenable for resection, we go for amputation, which is the final resort. And coming to the next complications. The complications are malignancy, recurrence, and pathological fracture. And another important thing is differential diagnosis. These are GCT-like tumors, which are brown tumor of hyperparathyroidism and chondroblastoma, osteosarcoma, especially the telangiectatic type, and chondroma. Next one, prognosis. Prognosis, metastatic GCT has a 5-year 76% disease-free survival, and a 17% of mortality rate. So probably it has a good prognosis. And finally, this one is, I mean, for your PG also, it's important. Like giant cell tumor, the mnemonic you can remember is 5 E's. These are epiphyseal, means epiphyseal in location, and it's an expansive tumor. And in X-ray, you can see eccentric location of the tumor. And on palpation, there is eggshell crackling. And finally, treatment en bloc excision is important. So this is about the giant cell tumor. It's a small topic. So briefly, what we have seen is giant cell tumor is a benign tumor, but it's an aggressive tumor. It's more commonly located. I mean, it's an epiphyseal tumor, and it's more commonly located in distal around the knee. First one is distal femur, followed by proximal tibia. It's more common in females and in around middle age. And histologically, if we see, mononuclear cells are more common in giant cell tumor, but giant cells are characteristic of the giant cell tumor. I'm telling you briefly about the giant cell tumor in a brief version. And in symptoms, pain is characteristic feature. And on palpation, there is eggshell crackling, swelling is present. And coming to the investigations, in X-ray, we can see epiphyseal tumor, which is eccentrically located, and CT scan is done to see whether lung involvement is present or not, and the extension of the tumor. MRI is done to see the soft tissue involvement, and bone scan is done. And next, coming to the treatment, in medical management, radiation therapy and medical therapy. Medical therapy, most commonly used drugs are denosumab and bisphosphonates. And coming to the surgical management, what we do is excision, next extended curettage, along with adjuvant therapy and reconstruction. And next one is complete resection and reconstruction, and final one is amputation. And coming to the complications, the complications are it may go into malignancy or pathological fracture can happen, and metastasis. So and another important thing is differential diagnosis: brown tumor of hyperparathyroidism, chondroblastoma, osteosarcoma, and chordoma. So finally, this is the mnemonic. Finally, we have discussed 5 E's. Remember this, and thank you.